Great. Thanks, Butch. Great to be here. So again, we're going to talk about why I prefer to do an anatomic total shoulder arthroplasty over a reverse in a patient over 75 years old with an intact cuff and osteoarthritis. So my strategy today is to talk about why anatomics are superior to reverses in this patient population. And my goal is threefold. Number one, it's because the function of an anatomic will outperform that of a reverse. We know that in anatomic replacements, patients have better internal rotation, and the best result from an anatomic will outperform the best result of a reverse. Number two, the complication rate with anatomics is actually not higher than that of a reverse. We'll talk more about that later. And lastly, the complications with anatomics are treated way more easily than those complications that you might experience with a reverse. And the caveat, of course, is in the B3 severely deformed glenoid. I think that we would all agree that reverse is a better option in those. The logic that we would prophylactically perform a reverse because of the worry that a patient will develop a rotator cuff tear may or may not be completely valid, as seen in the literature. So as we perform more and more reverses, Dr. Frankel just talked about how the volume of reverses is about 70,000 a year. Now, you have to be familiar with this complication profile as listed here. There was a paper a couple years ago looking at the difficulty in ADLs associated with internal rotation after reverses, and they had a list of 10 basic functioning lists of things that you need for basic functioning in ADLs, and there were significant diminished ability to perform these ADLs with the reverse, and over a third of these patients were unable to reach their back for washing and hygiene. Now, if we look at the complication profile for anatomics versus the complication profile for reverses, we know that the main reason for complication with an anatomic is long-term rotator cuff tearing or glenoid component loosening. Now, not all those patients will require secondary surgery, especially in this older patient population. However, with reverses, if you look at the complication profile being instability, infection, acromial stress fractures, or the painful reverse, the mystery painful shoulder that radiographically looks okay, I mean, we're looking at a pretty high complication rate, and the majority of those will actually need a reoperation. Looking briefly at 4 papers reviewing these concepts just published this year, the Australian Joint Registry now taking away the fact that a lot of these are metal-backed glenoids. You know, if you look at the complication rate of subtracting those metal-backed glenoids, there's not a significant difference in a 12-year revision rate when comparing anatomics to reverses. If we look at Melissa Wright's study published 2 years ago, comparison of anatomic and reverses in patients greater than 70 with OA and an intact cuff, this is a side-to-side, head-to-head comparison. There's no significant difference in complication rate or revision surgery when you look at the, if you look at the complications listed there, and over 30% of patients with reverses had markedly diminished internal rotation and trouble with ADLs compared to anatomics. Looking at the Mayo Clinic study last year, specifically at older patients greater than 70 years with intact cuffs and primary osteoarthritis. Complications are listed here, but the risk for revision surgery is really not that high. Secondary cuff failure is only 1.3%, of which only 0.5% required a revision surgery. And lastly, Brad Edwards' study last year looking at revisions with anatomics versus reverses in patients greater than 70 years old. The revision rate for reverse was twice the revision rate of an anatomic. And if you look more closely at this, the re-revision rate for the reverse is 1 in 4 patients. So once you have a revision, you have a 1 in 4 chance of requiring a secondary revision, and we know about the complications. This was nicely summarized by Peter Chalmers' paper 2 years ago, looking at revision reverse total shoulder arthroplasty. On average, patients can only get up about 90 degrees of forward elevation, and if you look at the complication rate, again, upwards of 10%, 30%, even 50% in some of these papers. So in summary, I feel like the anatomics will outperform a reverse in an intact cuff situation, and the glenoid deformity will dictate my decision on whether or not I perform an anatomic or reverse. And again, in summary, the complication profile and revision rate is not higher for an anatomic than a reverse. Therefore, I don't think that the benefits of the reverse outweigh the risks of reverse when you look at these complications that may require additional surgery or even more complex surgery. And in this patient population that's elderly, the revision of a failed reverse shoulder replacement is much more difficult with a higher complication profile than that of a failed anatomic. Thank you.